Okay, here we are back with part 4 of chapter 11 in patient assessment. We'll pick up right where we left off, where we were talking about the secondary assessment, and we just kind of assessed the hair. And so we'll pick up right there in the secondary assessment, and this is going to be, we're going to really be getting into the nitty gritty of patient assessment, and we'll be talking about all the different parts of the body and how we assess those and what we're looking for. It kind of gets a little tedious and monotonous, I have to admit, but it's all important. It's important things to consider when we're doing our patient assessments, and looking for all of those things so that we can form that differential diagnosis, or at least fine-tune that differential diagnosis. So we'll get going, and we'll start off talking about nails. You should assess a patient's nails for the color, shape, and texture, as well as the presence or absence of any lesions. A normal nail should be firm and smooth, and you should be aware that normal changes with aging include development of striations or lines and a change in the color to a small degree. But overly thick nails, or nails that have prominent lines running parallel through the finger, can suggest the possibility of a fungal infection. And what we see in the image there on your screen, that is clubbing, typically associated with some form of long-term respiratory illness or respiratory problem, such as COPD or something like that. It takes a while for that to develop, a number of years, but it's pretty much a telltale sign whenever you see that present in somebody's fingers. Here's some abnormal findings that we might see in the nail beds. The biggest ones that we're going to see is, as mentioned before, is clubbing. Is the big thing. Of course, bow nails and terry nails. We're not really going to see. We'll probably notice those things, but we're probably not really going to remember the name of them. So don't go making you any flashcards for those two disorders. Moving on to the head. When we examine the head, we'll use both touch and visual inspection to check for deformities, asymmetry, warm, wet areas, tenderness, the shape of the head, the contour of it, and whether there's any scars or the presence of any shunts, because they may have a shunt, installed. They may have a shunt, embedded that's, draining excess cerebrospinal fluid out of the cranial cavity. So we're going to evaluate the patient's face for its color, moisture, the expression, the symmetry of it. Does it look the same on both sides, as well as the contour. Also look for any swelling or other apparent areas of injury to the face. And there's actually a skill drill in this chapter 11, skill drill number 5, you can use to correctly assess the head if you want to use that particular skill. I do not know what page it's on, but it is in your textbook. The eyes can be used to assess the functions of the central nervous system. When assessing the eye, you should examine it from front to back, looking at both the anterior and posterior chambers, or at least as best that you can. You might not be able to do that without an ophthalmoscope. To assess the patient's visual acuity, you can use the Snellen E-chart to test their ability to distinguish between light and dark, or have them count your fingers. That can be helpful as well to kind of determine their visual acuity. Now, when we're assessing pupils, remember that they are normally round and of approximately equal size. In low light, the pupils will dilate, and in bright light, they will constrict, or they will shrink down into a smaller size. When you introduce a bright light to one eye, both pupils should constrict equally, and they should react instantly to any change in light. Check the pupils for their size, shape, symmetry, and reaction to light. Be aware of a condition called anoscoria, where the pupils are of unequal size. Sometimes you'll run into this, and it's completely normal for that person, though it can be quite frightening, and we immediately start thinking stroke or something like that has happened. So whenever you encounter that and things are not really adding up, be sure to ask that question. Now, if you've got a patient with signs or symptoms of a stroke and you see anoscoria, and it's still appropriate to ask them, are your pupils normally the same size, or is one bigger than the other? and that narrowing that down so that you can determine whether that is something that's relevant or whether it's a pertinent negative is really helpful. You should also evaluate a patient's muscle movement and whether their eyes can track all fields, including up, down, left, right, and across. To correctly examine the eye, you can use skill drill 6 in this chapter. The ears are involved with hearing, of course, sound perception, as well as balance, so they do quite a few things. The ear consists of 3 main portions: the outer, the middle, and the inner portion of the ear. Each one of these portions can be damaged, injured, or ill. They can be infected or something along the way, and it's going to cause the presentation of different issues. When you assess a patient's ear, check for any changes to their hearing, perceptions, wounds, any swelling, or any drainage. Also assess the mastoid process of the skull for discoloration and tenderness, which is known as battle signs. So right behind the temporal mandibular joint and right behind and below the ear, you can look for battle signs there. What happens is with some head injuries, it causes bleeding in the basal area of the skull. And you'll see battle signs like we see from people that have been in battle, that have been conked in the head. They get that battle sign. The nasal cavity is divided into 2 chambers by the nasal septum. Each chamber contains 3 layers of bone that has a superior, middle, and an inferior conch. When assessing the nose, you should look both anteriorly and inferiorly in the nose to see if there's any issues. As you examine the nose, look for asymmetry, deformities, wounds, foreign bodies, discharge, bleeding, and even tenderness. Note any evidence of respiratory distress and inspect the exterior of the nose for color changes, symmetry, or structural abnormalities. If you see something that looks abnormal or unusual, don't hesitate to ask the patient if this is normal or if this is something new. Finally, inspect the septum for any deviation from the midline and note any drainage or discharge. This is less important, and you're going to need like an otoscope or something like that to be able to look up in there anyway. But sometimes a severely deviated septum can be an indication that there's some other issues going on, especially if there's some kind of facial trauma, and that may be a new finding. You should evaluate the mouth, the pharynx, the neck. As the patient's overall hydration status, as part of that hydration status, pay attention to the condition of their lips, teeth, and oral mucosa. A prompt assessment of the throat and upper airway structures is mandatory to rapidly determine airway status in patients with altered mental status. During your assessment, check for the presence of any foreign bodies or evidence of aspiration. When assessing the mouth, look at the patient's lips and check for asymmetry. Inspect their gums and look for cyanosis around the lips, which is a sign of poor oxygenation. Finally, inspect the airway itself for any obstructions. When examining the tongue, check its size, color, and moisture. You should also check the maxillae and the mandible for their integrity and symmetry, making sure that there's maybe not a fracture or something there. When examining the oral pharynx, look for discolorations, pustules, unusual odors on the patient's breath, and any fluids that might need to be suctioned. Also, you should check for edema and redness to the uvula, the little hangy down thing in the back of the throat. When examining the neck, you should check for symmetry and masses. Look for venous distension, remembering to consider the patient's body position as you do. Palpate the carotid pulses and the suprasternal notch, checking for any tracheal deviation or the presence of a stoma. When assessing the cervical spine, you must consider the mechanism of injury. Evaluate the patient's pain and altered mental status and any loss of consciousness that occurred at the time of the event. Indications for spinal immobilization are going to include those things like tenderness upon palpation of the spinal column or a patient's complaint of spinal pain. You should also consider spinal immobilization if the patient has an altered mental status. If they're unable to communicate effectively, they have a Glasgow Coma score of less than 15, or has evidence of a distracting type of injury. Paralysis or other neurological defects or complaints are also indications for spinal immobilization. Remember, spinal immobilization is not something that we automatically do on every patient. We're going to wait until there's some indication that that is necessary that we do that. When inspecting and palpating the spine, check for tenderness and deformity. Pain is the most reliable indicator of a spine or spinal cord injury. Any manipulation that causes pain, tenderness, or tingling should cause the exam to stop immediately, and the patient should be placed in a properly sized cervical collar. It is essential that we properly size cervical collars. What was happening when we were placing every patient that was in a motor vehicle accident or every patient that fell in a cervical collar, most of the time we were doing a terrible job of sizing them correctly, and we were actually causing injury with the cervical collar itself. If we don't size the cervical collar properly, you can actually cause spinal separation. So it's important that we properly size every cervical collar that we put on, and we only put those on in those instances where it's essential that we do. A continued assessment of the patient's range of motion should only be done when there is no potential for serious injury, and this includes both passive, where we help them do it, or active, where they move the limb themselves. Remember, that's only going to be done in instances where we're not suspecting an injury to that particular limb. The chest exam has 3 phases: the chest wall, the pulmonary evaluation, and the cardiovascular assessment. We want to hit all of these areas. So when you examine the chest, we're going to check for signs of abnormal breathing movements and ventilatory fatigue. Also check the use of accessory muscles, which is a sign of respiratory distress, and for any chest deformalities. You should palpate any abnormal areas of the chest wall and consider using chest wall percussion to evaluate further. Listen over each of the 5 distinct lung lobes, having the patient take a deep breath through an open mouth each time. When you auscultate breath sounds, normal sounds should be clear and quiet. Bronchial sounds are hollow, tubular, and lower pitch and are heard over the trachea. Bronchiovesicular sounds are soft, lower pitched, and are found in the middle chest or mid chest. Vesicular are finer and somewhat fainter breath sounds heard during expiration. Now, when we talk about adventitious or abnormal breath sounds, we're talking about things like wheezing, crackles, rhonchi, stridor, and even pleural friction rubs. We're not going to get into those right now. When we get into that chapter over respiratory issues or respiratory illnesses, that's when those kinds of things are going to be talked about much more in depth. All right, so this just shows where we're going to auscultate and where we're going to listen to lung sounds. The picture on your right kind of gives you a lay of the land, so you've got an idea of where the lungs are located in the chest cavity. You know, for most people, for the average person, sometimes people are a little bit different. It's not always perfect. And of course, this shows a variety of different types of breath sounds, abnormal versus normal types of breath sounds. While it's one thing to talk about them and discuss them, it's a whole different story when you actually can hear them and understand them. Again, listening to lung sounds, it's important to understand what normal sounds like first. Once you know what normal sounds like, it's a lot easier to identify abnormal and then begin to narrow down what about that is abnormal and what is it. It may be more helpful to describe the sounds you hear rather than trying to classify them immediately. When you hear sounds, determine if they are dry or moist, continuous or intermittent, or whether they're coarse or fine. You should also determine if breath sounds are diminished or absent in a portion of the lung or in the entire chest. If breath sounds are diminished in a localized area, assess for transmitted voice sounds. So hold your stethoscope over that and have them talk while you're listening to that area and see what you hear then. And these are going to include regular breath or regular sounds as well as whispered sounds that whether or not you hear. Assessing transmitted voice sounds requires an optimal listening environment. That's why it's not done a whole lot. bouncing down the road in the back of an ambulance is not an optimal listening environment. So if you're going to do that, if you're going to assess that and use transmitted voice sounds as part of your assessment, you need to do that in an environment that's going to be conducive to that. Blood flows through two circuits: the systemic circulation, which carries blood from the heart to the rest of the body. Hopefully this is nothing new. And then pulmonary circulation, which carries blood to and from the lungs, from the heart. So that's why we have two sides of the heart. Those two sides of the heart are the two pumps that work, each one circulatory system and one's pulmonary system. One's systemic and one's pulmonary. And that's how the two sides work. The cardiac cycle involves the process of cardiac relaxation or diastole and the filling of the ventricles with blood. And finally, the cardiac contraction or the systole cycle of the heart. So relaxation and filling, and then ultimately contraction. The contraction and relaxation of the heart, I'm going somewhere with this, so hang with me. The contraction and relaxation of the heart combined with the blood flow that is generated, they create this characteristic heart sounds that you hear with a stethoscope when you listen over the heart. S1 is the first sound caused by the closure of the atrioventricular valves, which marks the onset of the ventricular contraction or the systole. S2 is the second sound heard, is caused by the closure of the semilunar valves, marking the onset of ventricular relaxation or diastole, and is usually louder than S1. It's the lub-dub, so it's a little bit louder. S3 is a soft, low-pitched heart sound that occurs early in diastole and is most commonly associated with increased filling pressures of the atria due to moderate to severe heart failure. S4 is a low-pitched sound, sometimes called a gallop, a rhythm, or it occurs immediately before the S1 sound and represents either a decreased stretching of the left ventricle or an increased pressure of the atria. The main thing is once again, it's like lung sounds, only probably even worse. You have to listen to a lot of normal heart sounds before you're going to begin to pick up on what's not normal. S1, S2 is what we're going to hear a lot of, and then sometimes you'll hear a swooshing or those kinds of sounds in there as well that's going to indicate there's something else going on. So splitting is when events on the right side of the heart happen slightly after those on the left, creating two distinct sounds instead of one. Of course, heart sounds can be heard at the chest wall and in the parasternal areas, superiorly and inferiorly in the region just above the left nipple. So it does matter where we listen, but we should be able to hear those sounds. They would get more clear the closer you get, the more centered you are on the heart. Korsakoff sounds are sounds you listen for when taking a patient's blood pressure. So when we take a blood pressure and we put our stethoscope over that artery, that's the sound we're hearing when we take a blood pressure. It's the Korsakoff sound. There are 5 phases to that sound, but only the first and fifth are considered clinically significant, and that's the 2 that we use to determine blood pressure. The first is the top number, the fifth is the bottom number, generally speaking. And that it may be sooner than that, but it's generally speaking, those are the ones we're listening for. Phase 1 is the first sound you hear, which is clear, faint tapping sound, gradually increases in intensity and corresponds to the systolic contraction. Phase 2 is the swift whooshing sound. Phase 3 sounds become crisper again and increasing in intensity, but are softer than the tapping sounds of phase 1. Then phase 4, the sounds become muffled, and phase 5, all sounds disappear, which corresponds to the diastolic pressure. So there's always been a little bit of controversy. Is it phase 4 or phase 5 of the sound? When that sound makes makes the muffled change sound, is that the bottom number, or is it phase 4? It's really phase 4. It's right at the start of phase 4 when it really starts to drop off and that sound starts to disappear, that's what corresponds with the diastolic pressure. In patients who have an oscillatory gap. The sounds may briefly disappear between phases 2 and 3. So sometimes the sound will disappear between phase 2 and 3. I can't explain why, but sometimes they will. Feel the chest wall to find the point of maximum impulse, and try to appreciate the apical pulse. Palpate for any lifts or heavies or heaves and a very strong heartbeat in the chest wall, which suggests hypertrophy. So if you have a really strong pounding feel through the chest wall, there could be some hypertrophy going on. It could be an enlarged heart. Be aware of any thrills, which are humming vibrations. A bruit is an abnormal whooshing sound that indicates a turbulent flow through a narrowed artery. A murmur is an abnormal whooshing sound heard over the heart that indicates turbulent flow around a cardiac valve. Murmurs are graded actually on a scale of 1 to 6 based on their intensity, 1 being the least, 6 being the worst, and those sounds start to get much more prominent. I would imagine most murmurs at a scale of 1, that us average medics probably wouldn't pick up on it, but if it reaches a 6, we're probably going to hear something in there that's getting our attention. We may not know what it is, but we're going to hear something. You're going to notice it. Again, as was mentioned in that video we watched in the previous section, we don't often listen to heart tones because they don't have a great impact on what it is that we're going to do in our treatment plans. However, if you're thinking heart failure or something like that, it's fine to listen to the heart tones and see what's going on. See if you can tell what's going on in there. It'll give you a better indication of what's going on. But whether or not that will actually impact your treatment plan is hard to say. So arterial pulses are a physical expression of the systolic blood pressure and are palpable whenever the artery crosses a bony prominence. Venous pressure tends to be low and does not assist in promoting systemic blood pressure. When assessing the extremities for signs of venous obstruction or insufficiency, you should look for venous engorgement. Sometimes you'll find palpable edema, swelling, and hyperpigmentation where that particular extremity gets brighter color, bright red, mild arrhythmia, painful superficial veins, and a feeling of heaviness in the extremity, as well as changes in skin color can be an indication that we may have a venous obstruction or venous insufficiency going on in that particular extremity. Jugular vein distension may indicate cardiac tamponade, with especially if you have penetrating left chest trauma. Pedal edema, we might consider heart failure as a possible cause. And be aware that even when the patient is supine, there may be no evidence of JVD if they are hypotensive. So realize that you could still have a cardiac tamponade in a patient that's hypotensive, and you might not be able to see it, relying solely on jugular vein distension. Older patients' ability to compensate for cardiovascular insult may be compromised by existing conditions like arterial atherosclerosis, diabetes, as well as some of the medications that they take, especially those for high blood pressure, or rate controlling medications that might prevent their body from responding to a drop in blood pressure where they can't compensate. You should pay attention to arterial pulses and assessing their location, rate, rhythm, quality, and amplitude. Obtain accurate blood pressure and repeat it periodically. Remember, we want to get a good baseline blood pressure, noting any history of hypertension and the specific category of hypertension the patient typically falls into, and we can kind of see that here on our screen. Most of them are going to fall into a stage 1. There is actually a pre-hypertension phase as well. Most are going to fall into phase 1. Some of them get up into the phase 2 category, and they're being treated for that as well. So those are also, they're noteworthy or good to know. You should palpate and auscultate the carotid arteries and listen for any carotid bruits. This will be an indication that maybe there's some plaque buildup or something, in that particular artery that could be problematic. And while it may not be directly related to what you're talking about, it is something that is noteworthy that does need to be shared with the receiving facility, especially if you're dealing with a possible stroke or a TIA or something like that, because that turbulent flow could be a part of what caused, the formation of a clot that's now lodged in the brain. For a suspected heart problem, you should assess the pulse for its regularity and strength, check the skin for signs of hypoperfusion or oxygen desaturation, listen to the patient's breath sounds, and get a good set of baseline vitals, as well as check the extremities for peripheral edema, because that'll give you some indication of how well the heart's working. And of course, knowing whether that peripheral edema is a normal thing or an abnormal thing will be helpful as well. So questioning your patient's going to help. The abdomen is divided into imaginary quadrants for assessment. We typically divide it into 4, but it can be divided into as many as 9 or more. The diaphragm is at the top, and the pelvis represents kind of the bottom area of that. The reason why we divide that into different quadrants is so that when we're explaining where a particular thing is, or a particular injury, pain, or something like that, we have a place that we can document where it's from. This is the one that I mentioned that was divided into 9 different categories. It's a lot more specific than the old 4 category one, and it can be a lot more helpful in narrowing something down when you're trying to explain where it's located. This one has the right hypochondrial, the epigastric, the left hypochondrial, right lumbar, umbilical, the left lumbar, the right iliac, the hypogastric, and the left iliac is how they're kind of broken down. And then you can, this is especially helpful in traumas, or, especially with penetrating wounds and that kind of thing, for you to be able to kind of pinpoint where those injuries are. The abdomen contains almost all of the organs of digestion, the organs of the genitourinary system, and significant neurovascular structures as well. The peritoneum is a well-defined layer of fascia made up of the parietal and visceral peritoneum. The intraperitoneal organs are the stomach, the paroxysmal duodenum of the small intestine, pancreas, jejunum, ileum, appendix, cecum, transverse colon, the sigmoid colon, the proximal rectum, liver, gallbladder, spleen, omentum, and the female internal genitalia. The extrapyramidal organs are the mid and distal duodenum, abdominal aorta, mid and lower rectum, kidneys, pancreatic tail, adrenal glands, uterus, renal, gonadal blood vessels, ascending and descending colon, and the urinary bladder. So you can kind of see how intraperitoneal and extraperitoneal organs that are contained. And remember, those intraperitoneal organs are going to be covered by that peritoneum. That's that thick layer of fascia. It's a tissue that's kind of covering that. What's interesting about that is it's very vascular and heavily innervated. It is entirely possible for a person to have a mesenteric infarction, where the mesentery, the blood vessels that feed the digestive organs, has an infarction, has a blockage, and it's called a mesenteric infarction. It's a different kind of MI, but it is still basically the same principle. There are 3 basic mechanisms that produce abdominal pain. There's visceral pain that results in hollow organ, when a hollow organ is obstructed, and the stretching of the smooth muscle wall. This typically produces more diffuse, widespread cramping pain. And then there's inflammation that causes pain by irritating the somatic pain fibers of the skin of the abdominal wall and the musculature. This usually results in sharp, localized pain. Referred pain originates in a particular organ, but is described by the patient as pain in a different location. It's interesting that abdomen does this quite a bit. So oftentimes, like gallbladder pain from gallstones or something like that, sometimes makes the right shoulder hurt, and not necessarily where the gallbladder is located in and of itself. It's called referred pain. I always kind of liken it to the fact that your brain knows something's hurting, but it can't quite pinpoint where it's at, because who actually fills their gallbladder? So the brain's like, I'm not really sure what that is that's hurting or where it's at, but it's kind of over here somewhere, and it tries to pinpoint it. I don't know if that's true or not, but it's a bit like watching a kid trying to use a spoon to eat with for the first time. So I just imagine that's what your brain's doing. You should obtain a baseline set of vital signs because they'll help you determine the seriousness of the patient's condition and the function of their internal organs. Shock can be present in different stages, and it may be noted by a decrease in blood pressure, but realize that a decrease in blood pressure may be a late sign in many people. Orthostatic vital signs, also known as a tilt test, can help determine the extent of volume depletion in a patient. But don't do an orthostatic vital sign test in someone you already know is in shock, because it's just torturous then. If you know they're in shock, there's no reason to do that. But if you're suspecting it and you need to use it to rule something out, then that's fine. In patients who are volume depleted, where there isn't enough circulating blood to push into the core circulation. This especially when they move from a supine to a sitting position, or from a sitting position to a standing position. All the blood kind of rushes away from their head, and they get dizzy, lightheaded, and sometimes pass out. The patient's blood pressure and pulse is then taken in the supine position and then the sitting position or the standing positions, and that way it'll help you determine whether or not they're having a positive tilt test, if they have a positive orthostatic test. Orthostatic vital signs are used in patients with complications of nausea, vomiting, diarrhea, syncope, and other gastrointestinal issues is typically when we use that. We're not going to do a tilt test on somebody that we're suspecting cardiovascular or neurological issues, just because we can cause more harm than good by doing it on them. A tilt test is generally considered positive if the patient's systolic blood pressure decreases by up to 20 millimeters of mercury and the diastolic pressure increases by 10, or their pulse rate increases by 20 beats a minute. Your documentation should include whether the patient's pulse was regular, if they are being monitored with an EKG strip, and if they are experiencing any other symptoms along the way. When you examine the abdomen, make the patient as comfortable as possible, which may involve giving them pain medication as well. Assess the patient in a supine position and always proceed systematically, performing inspection, auscultation, percussion, palpation in that order, quadrant by quadrant. You can describe the abdomen as flat, rounded, protrudent or bulging, scaphoid, or pulsating. And there's another skill drill that you can look at. It's like skill drill number 9. Will kind of help guide you in examining the abdomen. Ascites is fluid within the peritoneal cavity that may cause the abdomen to appear markedly distended. During an exam, you may see or feel a fluid wave, and you may find shifting or dullness to percussion. So it's just full of water. It's got a lot of fluid in there. Cullen sign or a Gray-Turner sign are both indicative of a ruptured ectopic pregnancy or acute pancreatitis. Both of these are very serious issues, which will be talked about more later when we get into the abdominal emergency section of the class, which is sometime in Care 3. But those two signs are typically ominous signs, bruising around the belly button. Auscultation may have limited usefulness in the pre-hospital setting because the environment must be quiet to hear bowel sounds. And of course, bowel sounds are described as hyperactive, hypoactive, or absent. You should listen to brutes or listen by listening over the aorta on the right and left renal arteries and the common iliac arteries. You could do that. It's not vital that you do. As far as bowel sounds go, bowel sounds are not something that we're overly concerned with, unless we've got someone that's, having some nausea and vomiting and those kinds of things. You might listen and see if there's some hyperactivity in there, or if you were thinking of there's an obstruction or something along those lines, we might listen to see if they're completely absent. So beyond that, they don't serve a whole lot of purpose for us. because we still can't see, we can't see a whole lot. They just are one of the things that we can utilize if necessary. So we palpate the abdomen to find tenderness. You should palpate each quadrant gently but firmly, and a normal abdomen should feel soft without tenderness or lumps and masses. Patient responses that indicate pain or discomfort include moaning or facial grimace and withdrawal. So while you're doing this, you need to keep an eye on your patient. Keep an eye and see how they're responding. Guarding is voluntary or it's involuntary. It's basically a contraction of the abdominal muscles, and it's considered a sign of discomfort. So they tighten up their muscles because it hurts, and when you go to push on it. This says to check for rebound tenderness, to push slowly and then rapidly release the abdomen. It's considered positive, and it indicates, a peritoneal irritation. It is painful for the patient, and it's not entirely necessary. By just doing a normal palpation of the abdomen, you're going to ferret out that they're having pain, and whether it's peritoneal irritation or retroperitoneal or peritonitis, whatever it is really not irrelevant. They have abdominal pain. Localized guarding and tenderness may indicate a more serious visceral problem, which can be an early sign of a serious condition, also associated with a bowel obstruction, urinary tract infection, and some things such as that. The big ones are going to be as abdominal aortic aneurysms and those kinds of things. And I realize you'll have a lot of other signs and symptoms going along with that aside from an abdominal issue. But if you have a pulsating mass in the abdomen, that's going to lead you in that direction. Pain associated with these conditions are often deep-seated and poorly described by the patient. So sometimes it's really hard to narrow down what's causing that pain, and it's not absolutely essential that we do. We just need to notate it and get transporting them. To palpate the liver, place your left hand behind the patient, parallel to and supporting the 11th and 12th ribs and adjacent soft tissues below. Place your right hand on the patient's right abdomen just below the rib cage and ask the patient to take a deep breath. As they do, try to feel the liver edge come down to meet your fingertips. Sometimes you can feel that. It all really depends on the size of the patient, whether or not you're going to feel that. In that video we watched in the last session where you put your stethoscope there and you rub your fingers across the abdomen, yes, that might work, but in a very large patient with a lot of adipose tissue, that's probably not going to be real accurate at finding the lower end of the liver. And really what you're looking for is hepatomegaly, as enlarged liver. When you're looking at the liver, that's what we're trying to discover or vet out. To palpate the gallbladder, use the same technique as you did the liver. You generally can't feel the gallbladder, but a patient's response to pain may indicate possible inflammation. The difference in techniques is that when the patient takes a deep breath, you move your fingers under the edge of the liver and feel for the gallbladder. And typically the indication is if they're having a gallbladder issue, it's gonna hurt and you're gonna know about it. You may only be able to palpate the spleen if it's inflamed. To palpate it, use the left hand to reach over and around the patient to support and press forward on the lower left rib cage and the adjacent soft tissues. With your right hand below the costal margin, press inward towards the spleen. These are all things that can be done, but they're not typically done. There's not a whole lot of need for us to palpate the spleen, but this is a way that you can do it. Realize not every paramedic is always going to be working in a pre-hospital setting. Some of them are working in a hospital or clinic setting. So there may be some of these assessment techniques for certain things, depending on the type of clinic they're working in, that may be useful to know or be familiar with and understand. All right, so an aortic aneurysm, as mentioned before, may be seen pulsating in the upper middle abdomen. If you suspect one, don't palpate the pulsating mass and minimize all manipulation of the patient. So this is a patient that's probably going to go on a long spine board so that we can move them without them putting any effort into moving themselves. So we want to be very careful about moving them. They need immediate surgery to correct this thing that's hopefully not bleeding out, but it may be. A hernia is a localized weakening of the abdominal wall musculature. It is not always visible, but to check for a hernia, place the patient on a supine position and ask them to raise their head and shoulders. This action will usually cause the bulge of the hernia to appear. Where the problem gets with these is, and we'll talk about this in the abdominal emergencies chapter, is when we wind up getting, a piece of the intestine that protrudes through that hole in that abdominal wall, and it herniates that. It cuts off the supply to it or something like that. That's when it becomes problematic. All right, just like that, we have flown through part 4 of patient assessment. So I'll see you guys back in part 5 for lots more fun.